Now it's time for the fun stuff. We'll admit in advance that this is some of the hardest stuff to remember in the book, especially as it's difficult to conceptualize why some drugs are used for various indications. Unfortunately, though, this is some of the most heavily tested pharmacology on the boards, and it's definitely worth your while to invest some time in learning it well. Along the way, we'll do our best to give you some acronyms and other mnemonics we use to keep it all straight. This first fact is designed for you to just have a quick hit list to refer to. We'll use it as a platform to discuss some of the commonly used medications for common psychiatric illnesses that we discussed during the pathology section of the chapter. While we won't read through all of these medications together, let's focus our attention on a couple of the important ones to remember. When thinking about medications for bipolar disorder, the main medications fall into two categories: the so-called mood stabilizers and atypical antipsychotics. The mood stabilizers include lithium, valproic acid, and carbamazepine. These all work differently, and it's not necessarily clear how all of them stabilize patients with bipolar disorder. Atypical antipsychotics, while effective for patients with schizophrenia, as their name may imply, have also become a mainstay of therapy in patients with bipolar disorder. It's important to remember specific drugs, if they are listed, for patients with specific illnesses. For example, while clomipramine falls in the category of tricyclic antidepressants, it is truly the only one that is prescribed for patients with OCD, so it should be remembered solely as a treatment option and not as a class. Similarly, mirtazapine is used for patients with depression with insomnia, as mirtazapine is well known for its sedating effect. Another key to remember about this list is that SSRIs fall into a lot of the illnesses. Often, it's hard to explain how and why this drug class has such a wide variety of effects, but suffice it to say it's a very important drug in the field of psychiatry. We'll talk more about SSRIs in a bit, but try to take note of all the diseases it can be used for. This makes SSRIs a very safe choice if a multiple-choice question offers them as an option. It's similarly important to remember which diseases don't have SSRIs listed as a treatment option. Two important ones to remember here are bipolar disorder and schizophrenia. The reason we don't use them for these is that the effects of SSRIs may exacerbate symptoms of mania or psychosis, and it would be unproductive in treating the root of the patient's disease. The first set of drugs we'll discuss is the CNS stimulants. These include methylphenidate, dextroamphetamine, and mixed amphetamine salts. Their mechanism is shown here. These work by increasing the concentration of catecholamines at the synaptic cleft, especially norepinephrine and dopamine. You can use this class of drugs to treat diseases such as narcolepsy. They can also be used to help regulate appetite. While intuitively it is not as clear why it helps patients with ADHD, it is most definitely a mainstay of therapy. Theories around its use center around the idea that it causes the brain centers that encode attention to become stimulated, which also suppresses distracting thoughts. This next class of drugs, the typical antipsychotics, is a very important one to study well, as it's very high yield. It's also a good warm-up, as unlike some of the other classes of drugs we'll discuss in a bit, these ones have some common name endings. The first thing to remember is that all of these drugs, with one exception, are part of a drug class called phenothiazines, and accordingly they all end in azine, and include trifluoperazine, fluphenazine, thioridazine, and chlorpromazine. Just remember, this doesn't include drugs like the antihypertensive hydralazine and the sulfa drug sulfasalazine or sulfadiazine, and the azines rule should work out well for you. The other classic drug in this group of typical antipsychotics is haloperidol. These drugs work by blocking the dopamine or D2 receptors, which work to increase intracellular cyclic AMP, as you may remember from your pharmacology lectures. It's very important to remember the mechanism of action for these drugs, as they can sometimes have interactions with other dopamine-altering drugs, such as Parkinson's medication and certain antiemetics like metoclopramide. Their clinical uses are fairly narrow, primarily as their name implies to treat schizophrenia, psychosis, and acute mania. However, they can also be used to treat Tourette's syndrome. The key in learning these drugs is in understanding their common and life-threatening side effects. Pharmacologically, these drugs are very lipid-soluble and are stored in body fat, which makes them take a while to be removed from the body. In terms of kinetics, keep in mind that they will actually partition into the lipid elements of muscle before adipose tissue due to the increased vascularity of muscle versus fat. The more common side effects from these drugs are mainly the extrapyramidal side effects. These effects often vary based on the duration of use by the patient. Within the immediate first 4 hours of use, patients may experience acute dystonias, including muscle spasms, stiffness, or even oculogyric crises. At 4 days, patients may notice achynesias with Parkinsonian symptoms. Then at 4 weeks, patients may notice akathisia, which in Greek almost literally translates to an inability to sit still. You can see why they used to mandate that all medical students take Latin and Greek. And finally, the late effects manifest as tardive dyskinesias. Tardive dyskinesia is characterized by stereotypical oral and facial movements. Once these begin, it's often difficult to reverse them, even with cessation of medication. Another set of side effects that are known to occur from use of antipsychotics are endocrine. This stems from the fact that increased levels of dopamine suppress levels of the hormone prolactin. Similarly, decreased levels of dopamine, which is induced by dopamine antagonists like the antipsychotic medications, will cause prolactin levels to increase, leading to galactorrhea and/or amenorrhea or irregularities in the menstrual cycle. Another set of side effects occur as a result of cross-reactivity of antipsychotics. Even though these are designed to antagonize dopamine receptors, antipsychotic medications will have effects on other receptors as well. They may block muscarinic receptors, causing side effects like dry mouth and constipation. They can also block alpha receptors, which would lead to hypotension, and they can also cause histamine receptor blockades, which can lead to sedation. In patients with acute psychosis or mania, this histamine blocking effect and the resulting sedation is a part of the desired effect when this medication is administered. The final side effect is one of the more worrisome and potentially life-threatening ones, albeit rare. It's referred to as neuroleptic malignant syndrome, or NMS. The symptoms of NMS are individually somewhat nonspecific, but as a constellation, there are not many diseases that look this way. The memory aid fever will help you remember these side effects. They include fever, encephalopathy, vitals instability, elevated enzymes, and rigidity of muscles. The muscle rigidity is often one of the giveaway clues if you have a question on this disorder. The other lab hematologic values which you'll often see elevated include myoglobin, which you may also see in the urine. Also, the fever tends to be very elevated to ranges that may not be compatible with life, often over 103 or 104, up to even 107. The treatment for this is prompt administration of dantrolene, which we'll discuss in the neuro chapter, and dopamine agonists to help reverse the effects of the drug. Before we move on, there's one final set of side effects that are worth remembering for two of the typical antipsychotics, chlorpromazine and thyroidazine. Both of these can cause deposits in the eye, however, they often go to different places in the eye. Chlorpromazine classically deposits in the cornea, and thyroidazine classically deposits in the retina. This memory aid should help you remember the distinction. It's important to remember that chlorpromazine and thyroidazine are low-potency antipsychotics and tend to have more anticholinergic, antihistamine, and alpha blockade effects, whereas trifluoperazine, fluphenazine, and haloperidol are high-potency antipsychotics and tend to have more of the extrapyramidal symptoms. You can keep these all straight with the acronyms cheating thieves are low for chlorpromazine and thyroidazine, and try to fly high for trifluoperazine, fluphenazine, and haloperidol. The next drug class is the atypical antipsychotics. These drugs are used to treat a similar spectrum of diseases as the typical antipsychotics, but they're often thought to have a more favorable side effect profile and are also more effective for the negative symptoms of schizophrenia, such as avolition and flat affect. There are 6 drugs in this class you should know: olanzapine, clozapine, quetiapine, risperidone, aripiprazole, and ziprasidone. You can use the memory aid "It's Atypical for Old Closets to Quietly Risper from A to Z" to help you remember these names, as they don't follow a pattern like the phenothiazines we just discussed. They work by blocking 5-HT2, a serotonin receptor. Like typical antipsychotics, they also antagonize dopamine, alpha, and histamine receptors. As we said a moment ago, the atypical antipsychotics are often used in schizophrenia, both for positive and negative symptoms, while typical antipsychotics are often used primarily for positive symptoms. Olanzapine, one of the atypicals, is also used for a variety of other disorders, including OCD, anxiety disorder, depression, mania, and Tourette's. While we did say these atypicals tend to be favored because they have fewer extrapyramidal side effects, they do have a few specific side effects that are worth remembering. One side effect that is specific to the atypicals is weight gain in patients that are taking olanzapine or clozapine. One classic board's question is that clozapine can cause agranulocytosis, so patients on this medication require weekly CBCs to check their WBC count. It may help you remember this by thinking that clozapine traps granulocytes in the closet. The next couple of facts will discuss a few individual drugs that are used in relatively narrow windows of diseases. The first of these is lithium. The mechanism of action is not well established, but it's thought to relate to the inhibition of the IP3 cascade. It's used as a mood stabilizer for patients with bipolar disorder, as it can block acute manic events. The side effect profile for lithium is fairly extensive, as it can cause tremor, sedation, edema, and heart block. The characteristic side effect you may be tested on is that it can antagonize the effects of ADH of the kidney, causing nephrogenic diabetes insipidus. Coincidentally, this also makes it a relatively effective treatment for SIADH, though it's not commonly used for this purpose. It's been largely replaced by dimeclocycline due to the latter drug's more favorable side effect profile. Another classic side effect of lithium is hypothyroidism. The final set of effects you need to remember is that lithium is associated with teratogenic effects in the fetus. The classic one is called the Epstein anomaly, wherein the right ventricle becomes atrialized due to downward displacement of the tricuspid valve. These side effects can be remembered with the memory aid LMNOP, another great example of my love of alphabetic mnemonics. Some pharmacologic characteristics worth noting are that lithium has a narrow therapeutic window, so serum levels should be monitored. It also is excreted entirely by the kidneys, and it gets resorbed in the PCT with sodium. Indeed, if proximal sodium absorption is increased, as in HCTZ or NSAID therapy, lithium absorption increases as well, sometimes leading to toxicity. The next medication we'll discuss is buspirone. This drug works as a serotonin 5-HT1A partial receptor agonist. As you may have seen earlier, this medication is used to treat generalized anxiety disorder. It's thought to be an effective medication in part because it does not cause sedation, addiction, or tolerance. It's this facet of the drug that's usually tested. I always remember this by remembering that you can't drive a bus if you're sedated. Unlike barbiturates and benzos, buspirone will not interact with alcohol.